If you're working with me, every patient has to take off their socks and shoes. My floor is clean. Can I get you to walk toward the door over there? And turn around, come on back. And now do it again. And why is she doing it again? Because there's too many things to look at. Okay? I'm looking at her patellae, where she's coming toward me. I'm looking at her heels and whether her navicular hits the floor when she's walking away from me. So what I'm looking for is specifically foot biomechanics and knee biomechanics. And the reason why is that so many lower leg problems of an overuse nature are based upon the cardinal two reasons or pathogenesis reasons why people get overuse lower leg injuries. So right now we're not talking about trauma. Folks, in family medicine, you are going to see probably about 20 overuse for every trauma you see in the lower leg. And so it's kind of important to know that rotator cuff tendonitis is number 1, 2, 3, 4, and 5 on my list of 5 things that we typically see. And that was the lecture that I gave 2 years ago. Patellar-femoral pain syndrome or anterior knee pain is number 1, 2, and 3 of the things that we see in family medicine. It's just so very common. It's not that you have your drive-up window at McDonald's and you can choose everything. Can you imagine the McDonald's menu and the top 5 items are patellar-femoral pain syndrome or anterior knee pain? It's just heavily skewed toward 1 or 2 particular diagnoses that you're going to see in family medicine. It's always important to remember that the others can be there, but as I said from the very beginning, you got to have a hit from the outside, valgus strain, in a sport like football or rugby to have an MCL tear. You almost never see it otherwise, okay? And so don't think of it in other contexts where there's no trauma. So in the case of a overuse sports injury, think biomechanical abnormality and training error. So what did they do that brought on this problem? What was different? Did they not change their shoes properly, like after 500 kilometers? Did they start running on sidewalks when they'd been running on forest trails? Did they increase their mileage? So now I'm going back into history and I want to stay with physical examination, but that's the reason why I'm looking for the other side of the coin, which is biomechanical abnormalities, which are leg length discrepancies, but more commonly excessive rolling in or pronation, or the high arch cavus foot, which is supination. Okay? So I look at the patient in the standing. I'm going to watch her walk. She has walked quite normally. There's no antalgic gait. I have the patient actually grab a hold of the tabletop. If you could turn around, face your colleagues. Now what I'm going to get you to do is actually pick one foot up like this, and I'm going to, not so high, and a little bit of a half squat like that, and back up, and switch legs, and down. And she actually moved a little bit medially with the right leg, which means that she's got a little bit tendency toward pronation. You're not going to see this examination done very much by the rheumatologists, the orthopedic surgeons. Okay? They're more interested in arthritis and things they can operate on. Here, I saw that little movement and I'm thinking, whoa, she might be a little bit more prone to pronation, so if she's in the wrong shoes, that might be a reason why she's getting these particular problems. And no, you don't have to do those, but what you should do is you should get her to squat down right on her toes. And can you do that, please? Right down onto your toes in that position. And if she can't do that, then she's got some significant pathology. Okay? But from there, what I'd like you to do is squat down there and walk like a duck towards your colleague over there.
And Clarke.
Okay. Perfect. Come on back up. Now, if she cannot, if you've got a meniscal tear, you cannot do that. So hence, my number 1 test for meniscal tear is squat and duck walk. Can I get you to sit up here, please? So we've done the standing. Is that okay? All right. Now, in the seated position, I'm going to inspect I think, David, we saw a patient yesterday whose one knee was much more swollen than the other. Just in order of timing, what do you folks have on next? How much time do I have? What time should I finish? Oh, no, I got patients at 10. But what I'm going to do is, in my chair, which is not here. Actually, can I have your chair?
Sure.
Thank you. Because, folks, I always preach to my residents and students, make yourself comfortable, because if you're not comfortable, you can't focus on what you're doing. What I'm going to do is I'm going to palpate from the tibial tuberosity right up the patellar tendon and right around the patella with my thumbs. I'm going to come back down and I'm going to go along the medial and lateral joint lines. I'm not going to look at the camera or at her knee. I'm actually going to look at her face, because if she grimaces when I'm pressing on that medial joint line, aha, meniscal test number 2. Okay? So those are some important things. Should we move over to the other table, or should we just bring your pillow for this table? Okay, so can we move the top of the paper? Okay. Now, I don't think David's seen a great. This David's got towels for you. Make yourself
Oh, the
comfortable.
one who volunteered me, you brought me towels.
Yeah, but you still owe her big time, man. Okay, so what I want to show you, and I think that some of you might see it better from the other side. There's lots of you behind me and sitting down. You won't be able to see. What I want to show you is that big slide I had with the wave. And I just cannot understand. I can't understand why they teach it that you go up that way and back down that way. Because the suprapatellar bursa is an open highway and the fluid travels this way. So why would you push down like that? And since then I had 2 chief residents from North York, and each one of them, they've got these bad habits and they're going up and down like that way. And they said no effusion, so I showed them my way, and whoa, there's an effusion there. So you know what? You have to trust me, or phone North York, because I go up like that, milk it 2 or 3 times, and then I go back up that way and look medially. Okay? Up, so the fluid comes laterally, back up, and the fluid comes back medially. That's where your effusion appears. And I don't know why they teach it the other way. This obsession with, yes, Dave?
Presumably, like the sensitivity and specificity and the norms they got from studies, though, would have been done with the other way, right? So your way, maybe is more sensitive, you know what I mean, than the sort of other way. It would be unknown territory, right? You have to do your own study.
Do you know the old dude in me says fluid is fluid, and my eyes are not as good as they used to be. Once upon a time, I didn't need these. But 3 months ago, no, about 7 years ago, I started having to wear glasses. But either you see fluid or you don't. So I grew up in an era where evidence-based medicine was in the future. And all I can tell you is fluid, and I think that my way, you just see a bigger bulge. End of story. There's patellar tap tests and things like that. But you know what? I think that's why I put that slide there, and that's why I spend so much time emphasizing it, because I think that it's cool to see an effusion, folks. It's cool to see it. It's one of the few things you see, but it's like that scapular asymmetry. You see an effusion and you're thinking, okay, well, my diagnosis is the same, but my management might be, hey, you got a bigger problem, lady or man. You got a bigger problem, and so you might need to see a physiotherapist. So I'll often examine the other knee, and I'll cheat. I'll reach over and I'll examine the other knee, and I will just see what the range of motion is like. Physios do active and passive. I do mainly active, but when I examine, I always try and examine the affected knee from that side of the table. Okay? So if you're lucky to have your table in the middle of the room, you can walk around the other side. Or if I'm examining a left knee, I'm going to have the head up here, and I'm going to examine that way. And the way I'm going to do it is I'm always going to have my hands in this position. So do you want to come on over here? And do you want to just put your hand in that position, your palm right on top of her patella, your thumb on her lateral joint line, your middle finger on her medial joint line, grab her hard by the ankle, and put her into, and move her through flexion and extension. Yeah, but now what I want you to do is look left. Look at her face. Okay? Because you want to see whether she's grimacing at any part of that. You don't need to look at the rest. Perfect. And the reason, thank you, and the reason why you're doing that is because I've seen people examine this way. Well, you don't have your thumb or finger on the joint line, so you don't know if there's going to be any tenderness at any part of the range of motion. If your hand is right on top, you're going to feel patellar-femoral crepitus. Okay? So what I then do is I will manipulate the patella in a number of different ways. Sometimes you have a high-riding patella. It moves way too easily. I'll move it up and down. Sometimes I'll press down and have you contract your quads. That's called the Clarke sign. As I press down, if that really hurts, that's just another test for patellar-femoral pain syndrome. Sometimes you'll see it, sometimes you won't. But then I'll start moving into the various angles. And the test that is so confusing to students is the McMurray Test. It's the one that has such low sensitivity, low specificity, and don't even try it if they can't fully squat. Because if they can't fully squat, it means there's fluid in the joint and it really reduces the sensitivity and specificity way below 50%. So it's a test from full flexion to 90 degrees. And I want you to look at my wrist on my right hand. Okay, don't look at anything else. There's my wrist. What I'm doing is I'm extending her from the fully flexed position, and I'm giving a torque of the tibia on the femur. Okay? So what I'm doing is as I'm extending from full flexion to 90 degrees, I'm rotating her tibia inwardly on her femur, trying to bring out something in the posterior lateral corner of the lateral meniscus. Similarly, as I go that way, see my wrist? It's all in the wrist. All right? Come try it. Oh, I'm feeling right here. I got my thumb on her lateral joint line, my middle finger on her medial joint line, because it's a test. And by the way, I'm looking at you folks because I respect you and I want to see that you're getting it. But when I'm doing with a patient, I'm looking only at her face, and it should be pain and a clunk. Go ahead.
So a positive is the pain, or the positive is the pain and clunk?
Reed's book, he says both. I'm sorry, I can't see what Dave's doing. Oops, my camera. Yeah, that's fine. That's all you really need to do. It's taught many different ways.
So you're evaluating both lateral and medial
Yep.
meniscus.
Yeah.
So
Lateral, medial. Okay?
So medial is an external rotation.
Yeah, I'm externally rotating your tibia on your femur. And I'm not going past 90 degrees. Okay? So, here's the old sit on her foot one. This is the anterior drawer. And I'm going, all my students tell me I cheat, but it's because I'm lazy, because it takes too much time to get back up there. But at 90 degrees, the major problems with this test, the anterior drawer, is that the hamstrings under here might not be loose enough to allow you to grab and pull, distracting the whole tibia forward. What you're looking for is you're looking for something that is very loose. So I want you all to take your arms, bend your elbow so that your hand is now close to your shoulder. You feel that as your forearm hits your biceps muscle, it's sort of like very soft, a little bit like skin on skin, okay? That is an end feel where there is no ligament stopping you. Now I'd like you to take your finger, and it might crack, but after it cracks, that is a ligamentous end feel. This is what you're supposed to feel in the knee. That ligamentous end feel, it moves but very little. This is going to be abnormal, that feeling in the knee where it sort of just squishes at the very end. And so what you have to realize is that very few people, this whole tibial plateau is going to come forward. That's a grade 3, okay? But the end feel, if you feel it differently on one side versus the other, that is significant. And you're going to compare from one side to the other. That's the anterior drawer test. Now, from 90 degrees anterior drawer, now I move into 20 or 30 degrees. Can I get you to come on over here? And what I want you to do is I want you to lock her ankle between your elbow and your rib cage. And you know what? Diplomatically correct ways of saying things. Female physicians with a male patient don't have their ankle up there. Down here, against your iliac crest, that's the position I want you to hold her in. Can you assume that position? Okay. So you feel her, you've got locked her ankle in there. That's a very nice position for doing the next series of tests. Okay? And also you're facing the patient, and that's important. So I'm going to take her back from you. Thank you. So this one called the Lachman Test. The Lachman Test, I always turn my hand over like that. Okay? If I have my hand like that, I'm not comfortable. If I have my hand like that, I'm not comfortable. Here I got her, she's not moving. I'm trying to prevent her femur from going up to the ceiling, and what I'm doing is I'm bringing my right hand, the hand on her calf, toward the ceiling. So I'm trying to see if that ACL is deficient or not. You want to come on over here and try that? So lock her with your elbow. That's right. Take your left hand right over top. So if you're doing her left knee, it's just the reverse, okay? So your right hand would be there and your left hand would be underneath. Okay, so pull up. All right, and you do it slowly because you're just trying to distract it, to see if that tibial plateau is coming up. All right?
Are you just pushing from below, or are you also pushing down?
I'm stopping this
Just
there
holding this?
and pulling this up, yeah.
Pulling up and just holding.
Yeah, yeah, okay, thank you. So that's the Lachman test. And at 30 degrees or 20 degrees of flexion, you can also take your hand and push her into valgus like that. There are two bundles of a very complex structure called the medial collateral ligament. And basically, there's an anterior component that tightens at 30 degrees. And if you press this way and she goes, oh, but at 0 and she doesn't, you know that part of the MCL is damaged, but not as much as if she had pain or gapping opening up with both. And so for 30 degrees, I go to 0 like that. At 0, I'm going to walk on the inside. I'm sheathing a little bit, and I'm going to push her into varus like that to test her lateral collateral. And then back here, what I'm going to do, do you want to come on over here, please? I'm going to do a variation of the same, and this is called the number 4 position. Number 4 position, I'm going to put my hand on her proximal tibia, but laterally, and I'm going to reach and grab my own wrist with my other hand, okay? And so now what I'm going to do is I'm going to push in a valgus force with flexion only to about 40 degrees like that. So this is called the pivot shift test, and the pivot shift test is a lot easier to understand if you think about what's really happening. The iliotibial band at full extension is an extender or extensor. Once you get past a certain degree, it flips and changes its mode and becomes a flexor. If you have an intact ACL, it grabs that tibial plateau and smooths that transition as the IT band changes from extensor to flexor. If you have a deficient ACL, all of a sudden, this is going to go from a nice letter J to big letter N or Z. Okay? And so what you're looking at is you're looking at a situation where it's a difficult test to do, but the more that you do, you're going to find... Do you want to try?
Jim, can I just stop for 1 second?
Yeah.
I don't want to stop you, but I just wonder if I could interrupt for 1 minute. Just Dr. Bizotti just would like to just quickly speak to the residents, and then he has to head out.
Sure.
Great. Hi there.